Hello. In the past 48 hours, we have created our tool known as DrugDecider, which is a functional opioid prescription clinical decision tool. We've all heard about the problems specifically facing the United States of this opioid epidemic that's contributed by overprescription of drugs. Currently, there are guidelines available, but they are subjective, and because pain itself is subjective, this contributes to a larger problem. Currently, there's no existing tool for physicians to determine who is a patient that truly needs these opioid prescription drugs versus those that are just patient or people who are just seeking drugs for recreational behaviors.
So our ultimate vision was to remove the subjectivity from opioid prescriptions, and the solution that we came up with was to develop an algorithm, which pulls information from the electronic health records, patient vitals, and clinical observations acquired during a patient consult. And all of this is to provide a real-time decision on which patients are eligible or not for opioids. So a quick little case study, we have Dr. Kevin here who's about to see a patient complaining of severe pain. So being the good physician he is, he starts collecting a lot of data regarding the pain severity as well as other clinical measurements. Now Dr. Kevin is a little confused because there's so much data and he doesn't know exactly whether the patient is eligible or not for opioids. So being the smart doctor he is, he feeds all of that data into our algorithm, which is combining multiple machine learning algorithms, including neural networks and generalized linear models, which provides a prediction as to whether this patient is eligible or not for opioids. So Kipp's going to do a quick demo of our algorithm.
So what we have here is a prototype of an external app. We also envision that this could be integrated directly with the EMR. So we have we've built this model, and so as you see, there's a lot of different data sources we can input. So you can look at medications that are enabled, different like vital signs, pain scale, things like that, demographics, medical history, social history, and eventually it'll come out and it'll give you a yes or no decision. It's very simple. Should I prescribe this patient? No. We can go through and we can change some things. So we'll say instead of taking codeine, he's never taken codeine, we'll put the pain scale up at a 10, and the result is a dynamically changed prediction for this patient. And then the other thing we have is to ensure that this is, to evaluate the quality of this, is that the physician is able to say, do you agree or not with our machine learning predicted recommendation, and then give reasons for us to kind of iterate on this process and keep constantly improving the model.
Really quickly, going a little bit further in terms of our business model, the constituents are the providers, whether it be a physician or nurse practitioner, as well as the hospitals whose EMRs we're drawing from, as well as the data from the patients themselves. In terms of the commercial potential, we'd like to start initially in the emergency department, but this is scalable to other specializations which are known to commonly prescribe opioid drugs. And lastly, the size of the market, as hospitals are moving from fee to service to quality of care, medical reimbursement is changing. The decision-making tool device industry is at $410 million by 2015 and is expected to increase annually by 22%. So with that, thank you, and we're happy to take questions.
There is reliable data telling the doctor how much and who should get prescription. I like the concept, but is there actual scientific data that you can make a acceptable prescription or not recommendation for how to prescribe? So your whole proposal is premised on the idea that you can tell a physician or nurse how much to give. Do we know that? If we have data to support there's a clear decision?
Yeah, that's a good question. So what we do with our machine learning algorithm is look for outcomes that are associated with drug-seeking behavior, and those are the response outcomes. And then we sort of do just a huge kind of variable selection approach to find which variables are associated with those outcome variables. And so they're actually, from our model, we had a good prediction rate success when we looked at these various types of statistics.
And just as a note, at the end, there's a comment section for the physician to say whether or not they agreed with our prediction model or not, and the reasons why, so that our model can continually learn and improve as it goes.
Can patients outsmart your system? You know what to say, what not to say, if it gets out in the
Yeah, to some
media, they can
extent.
say, I know, don't ever tell them I've taken any, whatever the first thing was before.
To some extent, that's unfortunately always going to be a possibility. However, by drawing such heterogeneous data sources, we can sort of, the whole point of that is the whole point of this algorithm is sort of get around some of that subjectivity. Whether that's completely possible or not is an open question.
And we're also tracking how many times that patient has come into that, to speak to that doctor.
Yeah.
Or
Yeah.
we're also tracking how many times that patient has come into that physician's office or into that facility. So we are looking at the,
But they can go to some other facility.
possibly.
Is it possible that, you know, because they go into the ER multiple times as well, as they can access the EMR through your app so they can know exactly how many times they went to the ER because they'd be seeing different physicians?
Yeah, we envision eventually this being directly integrated into an EMR system instead of a standalone app, but we could use the standalone app as well. So.